Hello and welcome to Talk 200, a lecture and podcast series to celebrate the University of Manchester's bicentenary year. Our 200th anniversary is a time to celebrate 200 years of learning, innovation and research, 200 years of our incredible people and community, 200 years of global influence. In this series, you'll be hearing from some of the nation's foremost scientists, thinkers and social commentators, plus many other voices from across our university community as we explore the big topics affecting us all. I'm Andy Spinoza, the host of Talk 200, and I'm pleased to introduce the first lecture of this series. In this episode, Chris Whitty, Chief Medical Officer for England, the UK Government's Chief Medical Advisor and Head of the Public Health Profession, discusses the past, present and future of health inequalities. As a society, we face the hard truth that the more socio-economically disadvantaged someone is, the higher their risk of poor health. The world's greatest killer is not any one individual disease, but the unequal way in which people are born, grow, live, work and age. Listen on to find out what the main drivers of inequalities and disparities in health are, how these have changed over time and why addressing them must remain a major public health priority.
Welcome to this special event, the launch of Talk 200, an exciting series of lectures and podcasts throughout 2024, the university's bicentenary year. I am delighted to welcome those able to join us in person for this wonderful event and the many more joining us online. Our 200th anniversary is an opportunity to reflect on our past, celebrate our present, and look to the future. And the Talk 200 series invites you to be part of the journey with us. Building on the success of our COVID lockdown lectures and the annual Cockcroft-Rutherford lectures, the series will feature some of the nation's foremost scientists, social scientists, and humanities researchers, as well as social commentators and many other voices from across our community. For example, to give you a taster of what's to come, the lineup includes our Chancellor Nazir Afzal, who will be giving a lecture on equity and justice as part of our bicentenary summer festival programme with one of the postmasters from the ongoing post office scandal, who will be joining the panel. We'll be celebrating our people, our inspiring staff and students, our pioneering academics, and other notable members of our community. This diverse lineup will provide insight on a range of themes central to our university's purpose and values, including groundbreaking discovery, social responsibility, and civic engagement. We'll be discussing Manchester's innovations of the past and how we're tackling global challenges today through cutting-edge developments in digital and AI, for example, and how we're addressing key issues in relation to health, environmental sustainability, and justice and equality. The Talk 200 series will comprise 4 in-person and live-streamed lectures, 6 recorded podcast episodes, and you'll be able to access all of these via our bicentenary web pages and the usual podcast channels. Tonight, our online audience can join in with the Q&A for both the lecture and the panel discussion by going to www.slido.com and entering the hashtag Talk200ChrisWhitty. So, we are delighted to begin today with a lecture from Professor Sir Chris Whitty, Chief Medical Officer for England and the UK's Government's Chief Medical Advisor and Head of the Public Health Profession. His illustrious career includes roles as Chief Scientific Advisor for the Department of Health and Social Care, Chief Scientific Advisor at the Department for International Development, and Professor of Public and International Health at the London School of Hygiene and Tropical Medicine. An epidemiologist, Professor Whitty has undertaken research and worked as a doctor in the UK, Africa, and Asia. His lecture, Health Inequalities, Past, Present, and Future, will consider the main drivers of inequalities and disparities in health, how these have changed over time, and why addressing them remains a major public health priority. Now, following Professor Whitty's lecture, there will be a short Q&A session with the audience, followed by a panel discussion. As a society, we face the hard truth that the more socio-economically disadvantaged or poor someone is, the higher the risk of poor health. The world's greatest killer is not any one individual disease, but the unequal way in which people are born, grow, live, work, and age. In Greater Manchester, our unique health and social care ecosystem means we can rapidly drive innovation and translation breakthroughs into real-world situations, which can then be scaled up and replicated across the globe in different healthcare settings. We have the opportunity to create real and lasting change. So, without any more from me, can I please ask Professor Chris Whitty to make his way to the stage?
It's a great honour to be here, and when the President invited me to discuss inequalities, I was very keen to do so, because this really is what drives a huge amount of public health. I'd like just to start off, because this is a global university, with one slide about the global situation, because I think it is stark and it makes the point very clearly. This is a famous update of a famous slide. Every country in the world is lined up with its income on the bottom axis and the lifespan, life expectancy, on the left axis. Two things really worth highlighting with this, and then one additional encouraging point. The first is that the line is extremely predictable. Poverty drives poor health outcomes in every country in the world. But more positively, the great majority of countries in the world not actively at war are moving steadily from the bottom left of this graph to the top right. And the graph scale is not clear on this, but it starts at around 50. At the point this university started, the lifespan in this city was in the 20s. And when the NHS was formed, the lifespan in the UK was roughly where it is in most countries in Africa today. So things have improved in every part of the world, but there is a very long way to go. Now, I'm now going to move over to the UK and specifically England. And again, this map, I think, tells a story that does not need laying out too heavily. The darker on the right, the colour, the greater the level of deprivation. This is the 10 deciles of deprivation. And on the left is under 75 mortality in the country. Those maps are essentially identical. Poverty and deprivation drives premature mortality with extraordinary predictability. Now, this is true in whichever kinds of infection or non-communicable disease you look at for different reasons. But I also want to highlight another reality of this. And on the left here, I've put a map of child mortality under 5 in the 1850s. And on the right, a map of COVID in its initial period in the UK in this century. And I think two things, there's a good point and there's a bad point. The good point is child mortality, of course, has massively improved over that time. But the bad point is the areas of deprivation where premature mortality occurs are incredibly deep-rooted and have remained the same in this country in many areas, including around Manchester. So this is something which I think we have to tackle as a matter of national priority. Some of the reasons for this are relatively easy to explain and with will and determination possible to tackle. I'm of course going to highlight smoking. And I'm delighted that the government is aiming for a smoke-free generation, people being addicted to smoking in their childhood and then suffering for the rest of their lives, something they do not wish to do. The great majority of smokers wish they'd never started and are forced to carry on by addiction, is one of the most appalling situations that leads to avoidable mortality in this country. On the left, we have deaths from respiratory diseases, particularly chronic obstructive pulmonary disease, but others, and on the right, lung cancer deaths. Smoking drives a very large proportion of the difference that we see here. So this is a relatively straightforward relationship because smoking is, the companies that promote smoking essentially do so among the most vulnerable. But there are also more complex relationships. This, for example, is on the right, liver cancer in the UK. And people often rather, I think, simplistically say, well, that's because there's more drinking in people who are living in more deprived socioeconomic areas. That is not true. In fact, the amount of alcohol, the number of people drinking it is higher in some of the higher socioeconomic groups, but the patterns of drinking are more harmful. So this is a bit more complicated. The more granular you look at the data for all of these diseases, the starker the differences become. And this has two implications. The negative one is we have an enormous gradient when you look at a granular level between the wealthiest and the least wealthy parts of our society. But on the positive side, from the point of view of what we can do, this tells us where we should go. There is a very clear concentration of poverty and deprivation-related illness and disability and short lives, and those are the areas we should be concentrating much of our effort. And this is true at however micro a level you go. This is a classic presentation. In this case of Manchester, you can do this for almost any city in the world, where there is a 10-year gap in very short distances between more deprived and less deprived parts of the city. And the same would be true in London, Glasgow, or indeed Paris and New York. Now, the reason that deprivation drives this premature mortality is multifactorial. Some of the factors are relatively clear, straightforward, and should be addressed through public health. Many of them are much more complex and based on issues around diet, housing, working environment, education. For example, education is highly protective against dementia and many other conditions. Smoking, as we talked about, but also importantly, there is something called the inverse care law. Those who need most medical help tend to be those who get it least. And this is a very important mission of the university in training doctors, nurses, and other health professions to ensure that we have people to serve those who are in the greatest need. So that's one huge driver of inequalities in this country. But I want to highlight another one, which I think is less discussed, and that is age. And here, the maps are very different. In fact, they are, to some degree, almost mirror images of one another in parts of the country. In the dark blue are the percentage of the population who will be over 75 years old. And as you can see, this is because of the pattern of migration internally in the UK, going to be very heavily in rural, semi-rural and coastal areas. And that is because the pattern of migration in the UK is generally for people to move into cities and towns in their late teens or early 20s and to move out typically after 2 children. So this pattern means that the ageing of society is happening in the periphery and the cities are remaining forever young. And you can see that very clearly on these demographic pyramids on the left. where Manchester, on the left, because of its student population, in large part, to which this university contributes, has a very young demographic, but the equation has to balance. And therefore, other parts of the country are aging extremely rapidly. And this is leading to a division of certain forms of disease. So diseases of young age are concentrating in the cities. I have picked out sexually transmitted infections. I could have chosen many others. This is a disease of youth, by and large, not exclusively, obviously. And on the right, I've picked out dementia, a disease principally of older age. These are in completely different parts of the country, driven by different risk factors. So this separation of diseases, which is actually accelerating, or at least progressing very rapidly now, is going to present us with very different problems in the future to those that we face today. And of course, most diseases are a combination in terms of their risk factors of age and deprivation. So here's coronary heart disease, and the two things that drive it are age and deprivation. So coronary heart disease rates are high, where there is both age and deprivation, along the coastal strip, for example, or in any place where there is either a high level of older people or a high level of people living in deprivation. What's spared are the areas of the country that are both affluent and young. If you superimpose most universities onto that map, I don't need to complete the sentence. And the same is true for mental health, for complex reasons, different parts of the lifespan, but obviously a growing concern, already a very major area where our research has been less effective than in some of our other areas of work. When we look at individual diseases, and I will come on to my views about what we should do next, but I'd wanted just to finish describing the issues. Let's just take cancers, and I've chosen cancers because Manchester University has over many years contributed so much to our understanding of both epidemiology and the treatment of cancers. Some cancers are very heavily associated with deprivation. Obviously lung cancer, head and neck cancer, liver cancer, at the top on the left there for men, on the right for women, lung again, stomach cancers, vaginal cancers. These are very strongly predicated on poverty. And smoking plays a very major part, as I'll come on to. But many of the cancers have very little gradient. So they will not be driven by deprivation, but they will be driven by age, because almost all cancers, not all, are very strongly age-related. So they will go in different directions in different parts of the country. And to make this, in a sense, slightly even more concerning, what I have here, this is unpublished data, but Cancer Research UK kindly allowed me to show it. On the left hand of each of these bars, these are all major cancers, is where the 10-year cancer survival was in the 1970s, and on the right is where they are now. There have been some stunning improvements. Melanoma, breast cancer, prostate cancer, Hodgkin's lymphoma. These have improved in terms of their survivals immeasurably measurably but very highly, compared to where they were some decades ago. At the bottom, however, we have a group of cancers: esophageal cancer, lung cancer, pancreatic cancer, and these are the ones in which there is a major socioeconomic gradient. So what we have been doing, and this is not deliberate, but it is a reality, is making substantial progress in those cancers where deprivation is not a major driver, and making much less progress in those cancers where deprivation is a major driver. And that is just a reality, that's a fact. You can see it in the numbers. Not for want of trying, but that is a reality. And once you then put together large numbers of diseases, you then see a picture which complicates this further. Most people actually do not, by the time they get to near the end of their life, have a single disease. They usually have multiple diseases, what's sometimes called multimorbidity. This, unsurprisingly, increases with age, so age is a major driver of this. But for anyone under the age of 80, it also is very significantly accelerated by deprivation. So people living in deprivation will typically get multimorbidity, multiple diseases in one person, making it much harder for them, their families, and for their healthcare up to a decade or more earlier than those living in areas of relative affluence. So this, again, has a very major inequality component, both on age and on deprivation. Finally, before I move on to a slightly more cheery part of my talk, but I did want to lay out the problem really clearly, it's important to acknowledge that whilst many things in child health have improved, we are setting up serious problems for ourselves in the future, and the biggest one, I think, to highlight at this point is people living with overweight and obesity. And the deprivation gradient on this in children is simply shocking. You can see the data on the left and where this is found in the UK on the right. These people will live with problems which will cause them longer-term issues, cardiovascular issues, diabetes, cancers, mechanical problems for the rest of their lives. They were set up to fail by the system we have in place, and this is driving obesity in areas of deprivation. So these are the problems that I think we clearly must, as a society, address. Now, what should we do about it? Well, I think the first thing to say is I consider this is a largely soluble problem if we are very serious about it. And this is both good and bad news. What this slide shows, and this is possibly the single most important slide I will show here, is that those who live in the most deprived areas live for shorter periods, but they also live for a much longer absolute number of years in ill health. Now, what that tells you, that's a bad thing, but what that also tells you is that if you can shorten the period of ill health, and you should be able to because biologically they're exactly the same people as the people on the bottom, they may live longer, but they'll have less time feeling unwell, they'll have less time in the NHS, they'll have more time with their families. Indeed, they'll have more time in economic employment. Many of these people are becoming unwell early in their working lives, in reality. So shrinking this period of illness, what's called slightly pompously compressing morbidity, should, in my view, be the central aim of what we should be trying to do in these groups. And I consider this as achievable, because what we need to do is delay disease. If we all lived to 150, we would all get cancers and dementia and heart disease and many other things, but we don't. If we can push diseases off to the right, we will shorten the period people live with them, and indeed, if we can push them off to the right beyond the point that someone naturally will die, because we will all die, then they won't have them at all. So if you were going to die at 80, and you have your dementia at 85, it's never going to be a problem. So pushing disease off to the right will compress morbidity, it will mean people will live longer, but it will also improve their lives and indeed reduce the amount of work the NHS has to do to support them. Why do I think that this is a realistic possibility? Well, because if you take the long view of medicine, it has had a stunning achievement in dealing with the diseases to which we have put our minds systematically, scientifically and politically. So this is the second half, roughly, of Manchester University's existence. In the first half, infectious diseases disappeared very largely from public view. They were still there just at the beginning of this. They're the dotted line at the bottom. Then we had a substantial increase in cardiovascular disease in this country, driven principally by smoking, but also by air pollution, working environments, and a variety of other factors, dietary and others. That peaked in around the 1950s. We then had a systematic attempt using primary prevention, stop smoking services and campaigns, all the things that reduced air pollution would be examples of that. Secondary prevention, which came a bit later down that path, where we started reducing blood pressure, dealing with high cholesterol and areas of that kind, and curative services. And the improvements we've seen, moving from a situation where roughly 1 in 2 people in the UK died of heart disease to roughly 1 in 4, which is where we've sort of moved to now, that has been done by a combination of primary prevention, secondary prevention, and curative services. It can be done, just as we achieved it with infection. And if you look at the extraordinary improvements in infection over the time that this university has been in existence, We've seen the end of cholera, typhoid, diphtheria, tetanus, TB very largely, and the bacterial diseases. And I'd just like to highlight on the right this sad painting by Lowry from 1935, the fever van. The medical officer of health would arrive, a child who had an infectious disease would be taken from their parents, all their belongings would be destroyed, they'd be taken by the state into isolation, and their parents might never see them again. Those kind of pictures are now not seen because medical science has, by a combination of prevention and treatment, de-risked those diseases. So I've just taken cardiovascular disease and infection in their contexts. And in many of these areas, these improvements continue. So this is from 1970 through to just before the COVID pandemic. This is coronary heart disease in younger people. And again, a stunning improvement over that period where the difference between men and women has significantly reduced because that was largely driven by much higher smoking rates in men. Those have come down. Sadly, rates in women went up, coming down again now. But public health and curative medicine combined have achieved a great deal. Scientists here, as elsewhere, have contributed to this. We could, by the single action of stopping smoking, substantially reduce the cancers which are most prevalent in areas of deprivation. 1 in 5 deaths from cancer in this country are due to smoking, maybe going up to 1 in 4. And 1/5 of cancer deaths in the UK are due to lung cancer, the overwhelming majority of which is smoking. So here is something we know what to do, and it is simply a matter of do we have the political will to do it. Then moving on to some of the issues of older age, as I said earlier on, I think that we now need to think very seriously about what we're going to try and do to support people in older age and to improve the health in a realistic way. And if you talk to the average person walking up and down Oxford Road and say to them, I can give you 2 years of life in bad health or 1 year of life in good health, the overwhelming majority will say, I want the 1 year of healthy life where I can see my family, see my grandchildren, enjoy my existence. Not all. This should be someone's individual choice. As a profession we have in medicine, as a profession we have in science, concentrated for a long time on trying to improve longevity, and we have achieved that to a very large degree. On the bottom of these graphs, what you can see is under 75 mortality. It's been falling for a long time. I'll come to the caveat to that. Over 90 mortality has hardly moved at all now for a long period of time. And that we should not see as a failure, provided those people are living good lives. Finally, I'd like to finish with one bit of cheerfulness and then one bit of moderately uncheerfulness and then a summary. This is what has happened to life expectancy in England over the period that this university has existed. I put the arrow where the university began. I'm not claiming causality, but there is undoubtedly association. And science has done so much, as have the doctors trained, nurses trained in this university done so much to contribute to this extraordinary turnaround in mortality. There's a but to that. If you extend the line further to the end, all of Europe, not just the UK, it's often ascribed to an individual country, all of Europe saw an inflection point roughly at the time when the big financial hit occurred. That's not particularly surprising to anyone in public health. We all know that if you increase wealth, you reduce health. You shouldn't be surprised if the opposite is also true. It is true. You can see it on that graph. This is every country in Europe. Big country in Europe. But there are two things you should see with this. The red line is the UK, the dark blue line is the rest of Europe, and we have been drifting down the leaderboard for some time. Slowly, it's not one particular issue, and then of course COVID had a major hit for everybody in the UK and elsewhere, and we've got to recover also from that. So my summary from all of those points. Health inequalities due to deprivation and those due to age are both serious We need different approaches to them, and they are diverging geographically. It's no longer going to be realistically possible to only go to areas of deprivation. I think we need to think about both. We should have as a major aim shrinking the period of ill health. Because if we do that, longevity will follow as night follows day, but the principal point is that people want to live a good and independent life. Shrinking period of illness is the key to that. In my view, this is entirely possible if we aim to delay disease and start in the areas of deprivation, which you can see extremely easily if you just map them out. And we should have the same self-confidence to do that as the people who addressed infectious diseases and cardiovascular disease in the last century, where they just said, we're just going to do this. Wider social interventions, non-health interventions, are of course essential, but we as a profession need to target primary and secondary prevention. Primary prevention, we do it to everybody before they get disease. Secondary prevention as an individual intervention when people have got particular risk factors. And finally, turning to Manchester. Manchester has some of the best scientists, one of the largest medical schools, one of the most important areas of training for nursing, and it has also some of the greatest inequalities in the country. If you wanted to start somewhere, you couldn't start in a better place than Manchester. This is a serious thing we ought to tackle, and good luck.
Thank you, Chris, for a really vivid and shocking presentation of both medical and social science evidence of the connection between social inequality, place, where we live, and health outcomes. And by implication, the requirement for interdisciplinary teams and interdisciplinary solutions to get to your clear vision of healthy end of life. We now have time for questions from the floor. Can I ask you all to be very well behaved? Wait until the mic comes to you so that everyone in the room can hear, but also those joining us online. And my first question, I think, comes from the second row. Thank you.
Thank you, Colette. I've been keeping an eye out on the Slido, and the first question that we've had through is, how can partnerships, strategic partnerships between philanthropists, universities, and other stakeholders be leveraged to address health challenges effectively?
So I think that the question, in one sense, answers itself. You need money for research, you need money for some of the interventions that we need. The state does that well in some areas. Philanthropy has had an enormous role in others, and I worked, for example, a lot with the Bill and Melinda Gates Foundation internationally, with the Wellcome Trust here, and other philanthropists as well. But I do think that universities have a very major role to play for two reasons. They train the people who will be still working on this problem in 40 years' time, and they undertake the research that means we can tackle it in new ways, accepting that if you don't move on, don't be surprised if the problems don't stay the same. So universities, I think, have an absolutely central role to this in multiple ways.
Thank you. And just behind you, thank you.
Thank you so much for a wonderful talk. I really enjoyed that. My name's Anthony Jones. You spoke so eloquently about the classical diseases. And in order to improve people's health, you need change in behaviour, for which mental health is obviously crucial. And you didn't speak much about that, and I wondered whether you'd want to comment on that aspect.
Yes, so, I mean, I put one side, I was given a very stern instruction that if I stopped, I had to do 20 minutes, so I decided I wouldn't, I didn't want to do it poor justice by essentially giving a glib answer. On mental health, I would make 3 points on this. The first of which is mental health tends to first present in late childhood, adolescence, or early adulthood. Very different to many of the other diseases I was talking about. This also means it tends to concentrate in urban centres, and I think we are much less systematic about facing that reality. We know that there is a significant workforce problem both for child and adolescent mental health and also with adult health, so that's an issue. But I think there are two things that we have not really tackled adequately. The first is scientific. The treatment of most of the diseases I deal with now is transformationally different than when it was when I was a medical student. In mental health, an awful lot of what I do now for the non-severe mental health, and even that specialists do for more severe disease, is very similar to what it was, implying that in science we have not managed that transformation we've achieved elsewhere. So I consider that a scientific failure by us collectively that we should be aiming to address. The second is the significant rise in people reporting mental health concerns and mental health issues in younger age over the last period, which was accelerated by COVID, but definitely not, it was clearly happening before that. We do not have an adequate explanation for that, how much of it is diagnostic changes, how much of it is actual changes in risk factors, what we should do about that. So here we have a significantly increasing problem, and I don't think we have put adequate resource intellectually as well as monetarily into trying to solve it. So I think the gap you point out is a very important one. And as the map of mental health burden I showed demonstrates, as with many other areas, this is quite concentrated in particular bits of the country, including around here.
Thank you. Do I have more questions? Another one from Slido. Thank you.
Thanks, Chris. We've had a couple of questions built around a similar theme, which is about, from Stephen Lowe in our online audience, deprivation ties into access to green space and lifestyle. Are there connections between healthy environments and healthy populations, and how do we influence this?
There are very clearly connections between unhealthy environments and poor health subsequently. And there are multiple ways this plays through. Some of them are relatively straightforward to describe, like crowding, for example, very strongly associated with certain infections. Lack of access to exercise, exercise a major protective factor for many diseases, physical and mental. There's also areas which intrinsically sound as if they should be correct, like green spaces, coastal spaces provide better health outcomes, and that is true, but it is a complex relationship. And if you look, for example, at coastal areas, which are both beautiful and have coast and often green areas, they often also have high concentrations of poor health. So I think we should accept that there is clearly a correlation, but it's often quite a complex one, and one which I think we need to unpick. I think as we're moving into a greater concentration on things like social prescribing, I think we should be trying to make a much clearer differentiation between the impacts on physical and mental health due to the environment.
Thank you. So we have one more question, and I'm going to give the privilege to Professor Dame Nancy Rothwell. Thank you. I couldn't do anything else, could I?
Oh, of course you could. Well, first of all, thank you, Chris. That was fantastic. Interesting, the stark geographical differences. Do we or should we be putting different health care systems based on geography of known incidents? Because I'm not aware that we do. Much more concentration of mental health, where there are young people in cities, much more concentration of the diseases of the elderly. And it seems to me that there is a powerful argument for it now.
Yes, I think we should be accepting that, because I think that the diseases of deprivation, the diseases of older age are separating geographically, and that is going to continue. The logical response to that is to actually redeploy our resource, both scientific and clinical, and also public health, to essentially go down those two different areas, accepting there's a lot of overlap. And of course, there are large numbers of older people in urban environments, just as there are many people not living in deprivation and in good health in rural ones. But I think it does not make sense to try and provide the same service and with the same ratios everywhere in the country when you start looking at those graphs and see where they're heading.
Thank you. So, those of you who put your hands up a fraction too late, please hold your questions for the panel, particularly the gentleman there in the fourth row. Thank you very much. Thank you very much for continuing the discussion with Chris, and now I'd like to take it further with the panellists joining the stadium.
So thank you, Colette. Thank you very much, Chris. I loved the way you brought Manchester into so many of the discussions. Very nicely done. But can I, first of all, invite the other panellists to just introduce themselves briefly? Nikki?
Hi everyone, I'm Nikki Cullum. I am Professor of Nursing here at the university and leading for the university on health inequalities at the moment, which is a major strategic imperative for the university.
Jane?
So I'm Jane Pilkington. Good evening, everybody. I'm Director of Population Health for NHSGM.
Great. So I'm going to ask a few questions, and then you can be thinking of your questions to follow up in a few minutes. And the first one I'm going to address to Chris, but first of all, I have to remind you again, if you're online, you can go to www.slido.com and then enter the hashtag Talk200ChrisWhitty. But Chris, we all saw you very regularly on the television during COVID. What should we be doing now to prepare for another pandemic? Because surely there is likely to be one.
So I think what we shouldn't be doing is trying to write a plan for the next pandemic. Because if you think about the last really serious one we had, it was HIV. Different age group, 100% mortality in those who had it, completely different routes of transmission, etc. So the idea you can just take a plan off the shelf clearly is incorrect. What we do need to do is have the building blocks ready to address almost any major infectious outbreak we can have. We will continue to have them for the rest of time. They'll go down different routes of transmission. Some will be oral, some of them will be respiratory, some will be sexual, some will be vector, and so on. But I also think what we saw really clearly, and I hope that came across in one of the slides I showed early on, is a concentration of the worst impacts of COVID in areas of deprivation, as has happened with virtually every other infection previously. And what was really clear, and it is a real problem, is that we are not being effective at engaging with certain communities living in deprivation across the board. Not just on infectious diseases, vaccines and so on, but also on cardiovascular disease, also on mental health, also on maternal services and so on. So we must make much more effort, I think, to engage with communities and keep that engagement going rather than just starting to pay attention when a crisis hits. I think they rightly felt that we, in a sense, only woke up to the problems they were facing when there was a crisis, and that isn't correct.
And I'm sure you've seen the graphs, for example, in Greater Manchester, the vaccination rates map precisely onto areas of deprivation, and public trust is a big thing. So, Jane, can I just ask you, what ways, in your opinion, have healthcare systems adapted or failed to adapt to challenges posed by health inequalities? And what can we do about it?
I think healthcare systems could and should do more. However, I do think that integrated care systems are a major step forward, really. For the first time, integrated care partnership boards have a statutory duty to address health inequalities alongside their functions for population health and promoting social and economic development. And I think the place-based nature of integrated care systems mean that they have to work across traditional health boundaries, but also with non-health partners. And that means that they can focus not just on inequalities in access to healthcare, but also actually the drivers of ill health and the wider determinants. And that's really true where you've got mayoral combined authorities like we have in GM, because we have more of our hands on the levers of the causes of ill health, whether that's transport or housing, etc. But I think if I was thinking about reform, there are three things I think are really important. I think endurance is one. Health inequalities, it's a really long-term endeavour, and it needs to go beyond kind of political attention spans and planning cycles and leadership tenures. We need to focus on the long term, and we need to think about action in the short, medium and longer term. And we also need to be really clear about what does success look like and how are we going to measure it. I think my second point would be around partnership approaches. No one agency or sector can do this. It's got to be a multi-agency effort, and we need to do a lot more really to develop the contribution of our communities around that. And then finally, I guess for me, a point about disruption. If we want upstream healthcare to be a mainstream model for us, and that's really important. You know, if you look at GM, 1.1 million of our population, or 4 in 10 of our population, live in the most deprived quintiles that you were describing earlier, Chris, which means we need our health system to respond to their needs properly. So we need universal healthcare, but proportionate and targeted to need. And that means a real shift in what the NHS prioritises, values and regulates. And if we want to hardwire health inequalities and take it seriously in our system, we need to think about endurance, partnership and disruption.
Thank you. Nikki, I mean, obviously a lot of this rests on health service, public health, etc. But what role can we as an academic institution or any academic institution play in alleviating health inequalities? This is your day job, so it should be an easy one for you.
Well, I think Chris made some really brilliant points, far more eloquently than I can, in his lecture, actually. And some of that's about schools as academic institutions, and some of it's about universities and FE colleges, I think, actually. So increasingly, we've heard about the problems that children and young people have with mental health and well-being. And I think schools probably play an important role in identifying that, in spotting that. And we have a major research programme here based at the university called Be Well, which some of you are probably involved with, which is about working with school-aged children to really start to understand on a cross-sectional and a longitudinal basis what are the things that are driving their happiness and their unhappiness, and co-designing with them interventions to alleviate some of that. So we've got to understand it better, and that's exactly what Chris said in his talk. So I think they've got a role in sort of some data-driven insights, which universities can and are helping with, I think. I think in terms of universities, I think obviously we've got a major research role to better understand some of the root causes, to better work with, for example, our ICSs and help them with identifying what are the best evidence-based policies for early detection, prevention, secondary prevention, and help support those kind of policies in terms of rollout. But obviously the universities have also got a major role in education and training, healthcare professionals, but also I think our wider student body in understanding the factors which underpin unfairness and inequalities in society, and understanding the more underserved groups and communities and what they need to be supported with in order to be more fully engaged with wider society in health and education. So I think one of the things that makes me really proud about you working at the University of Manchester is the civic responsibility, the social responsibility agenda. And I think we're probably at the beginning of a journey for that, really, which is about engaging the wider communities in everything we do, whether it's education or research or health research. And by doing more of that, I think it's part of the way in which we can reduce unfairness and inequality.
So, I mean, this could be to any of you. Are there health systems around the world that we can learn from, that do it better? I mean, there are many countries without a national health service. Some was good. Can we learn from other places? I don't know who wants to answer that. Chris, you must have looked at quite a few international, but anybody else can do.
Well, I mean, we learn most from countries that do things very differently to us.
Oh, okay.
Or countries that are very similar to us and taking a different line. Yeah. So I watch what happens in Scotland, for example, because it's very similar. I'm also very interested in what happens in East Asia and Latin America, because they have a completely different approach. And many of the things that we've learned, I think, from those countries are things which you just think, I wouldn't have thought of that from first principles at all. It just doesn't follow the line we're going for. So those two seem to be the ones we can go to. There is no single country you can look at and say, this is the answer. There are many countries that have got particular components that they do very well, including many low and middle income countries, which actually address, for example, community provision of healthcare often in an extremely imaginative way. And I think we should learn from them as well as learn from high income countries, which look more obviously our peers in terms of the ability of the health service to respond. So I think there is a lot to learn, but there isn't a country we can say, if only we were.
Yeah. So anybody might want to answer this question as well. Do you think we need to redesign the way we train our healthcare professionals? I mean, Nikki, you trained as a nurse, and I'm not sure what you trained in, James. Public health as well, both in public health. Do we need a different sort of health education system to the one we have now?
Well, I don't know about a different education system. We certainly need a system that makes it more attractive for people to come into these professions and stay in the professions. I think one of the massive challenges we face is a workforce issue across healthcare. And one of the reasons why we absolutely do, I think, need to learn much more from low and middle income countries in how we deliver prevention to broader sections of the community without lots and lots of healthcare professionals.
Yeah, go on, both of you. Go on. Yeah, go ahead, Jane, and then I'll go to Chris.
Just add into that, I think I speak to our provider organisations quite a lot, and they're really keen to say, how can we get a skills escalator and local employment pathways so that we make these careers attractive, but we're growing our own. And I think that would really help reduce health inequalities, and we need a workforce that is literate in health equity and that is fit for the future and can actually deliver services and work with those communities that we need to work with, because it's in those communities at a hyper-local level where we're going to make the difference.
Yeah. Chris?
I think over my professional lifetime, training all the way through the system has become more and more regimented and less flexible. That is completely the wrong way to go. And I think we should be maintaining flexibility for people around their careers and also maintaining generalist skills, because multimorbidity will only be tackled if we move away from just saying everyone has to be a specialist. You can be a specialist and a generalist at the same time, and we should celebrate both. But I really think bringing back flexibility to the training system would have multiple benefits.
Yeah. And we've talked obviously a little bit about the healthcare system, about universities. What role do you feel that industry can play in this? I mean, obviously in terms of funding and development of new treatments, but actually in their workforces, removing health inequality in the workforce. Do we engage with industry enough?
I think we've got some good kind of private and public partnerships. I mean, Health Innovation Manchester is a key part of how we're working, isn't it? And I think those cross-sector partnerships are essential to bring in that additional capacity, the expertise and innovative thinking. And I think if we go back to COVID, the kind of partnerships we had with industry there and the rapid innovation we had in developments of the COVID vaccine, its rollout, were incredible. And I think we need to kind of make sure that we sweat that asset and really, we have that capacity building and that knowledge exchange. That is really important if we want to be cutting edge in Greater Manchester
Chris?
and beyond.
Yeah, I mean, I think that leaving aside the ones where it's really obvious, like pharma and so on, I think there are two bits of industry that we really, industry in the broadest sense, that we don't engage with as much as we should. The first is engineering in the broadest sense of that term. If you look at most of early public health, it was engineering driven. If you want good housing, if you want people to be able to exercise, if you want people to have clean water and so on, it's engineers, but it's also the way they think through problems, and they have a different approach to people trained in biomedicine, and it is extremely powerful, and actually learning from them and an approach to thinking. And I think universities like Manchester, which have both strength in both, are in a very strong position. The other way is that most people will work in a private sector environment for 40 years of their life. And we've been incredibly unimaginative about using that time to promote health and decrease the chances that long-term ill health occurs. We've been very good at stopping accidents at work and occupational diseases. That's been a phenomenal response. Moderately good at dealing with people who've got a fixed form of disability. It's not great, but it's better than it was. But there's using it as health promotion, dealing with people in a way that allows them to continue a career if they've relapsing and remitting conditions. I think we've got a long way to go on that, and I think we really need to have a proper rethink of it.
And what role, we know there is already a big role, do we see as digital and AI in helping with the future of health and health inequalities? And along with that goes a big issue of public trust. I heard the scary figure that 43% of the population of Greater Manchester are not fully able to use health care apps or GPs and so on. I don't know who wants to.
But I'm very confident that younger members of your university are using AI a lot more than you are.
Absolutely, I could absolutely not disagree with that. Yes. But we know there are big parts of the community, particularly the older parts, who are completely digitally illiterate.
AI is going to transform diagnostic radiology, for example. Absolutely. I think it will transform diagnostic pathology, for example, slightly slower time. Some of the claims for AI, I think, are exaggerated, for no doubt about it. But as an ability to actually support us in what we're trying to do, I think it does have a major role. And I think we currently use it rather cautiously in education. And I think it will have quite a big role in helping people to learn things who aren't necessarily going through formal university, but actually could learn skills which are relevant to health and social care. So I think there's a lot positively we can do. Of course, all the caveats need to be put underneath that.
Yeah, we do have quite a large and very eminent group in digital trust, and we're now looking at broadening that into digital trust and cybersecurity and safety of online data, which I think is going to be a big issue for future.
Well, I think one of the challenges is access to data for research purposes and for doing research with routinely available data that can then improve health overall. I think things are moving quite fast in that space. It's still painfully slow, I would say. So the quicker that we can make that smoother, the better. When we've done some research here in the past on trust, though, people were we did a citizens' jury, and people's decisions about which organisations they would trust with their health data were quite nuanced, actually. All were not equal. So I think there is, there's a job to be done, I think.
Yes. And also, I mean, one of the things, we all criticise it, but what is probably a huge and underused asset is our National Health Service and the data within it. We still haven't really cracked the use of that. When you look at us, many companies in the States want to come in here and use our data because they just don't have it. So, Jane, you wanted to...
I mean, I do think that's one of the important things, is thinking about a knowledge power NHS, so that actually all the data we're gathering around individuals and their interventions, that we're putting that to good use in terms of learning. And I think we now have a very good longitudinal data set and an advanced data science platform. So we've got some unique data architecture here that I think will be really attractive to industry and to researchers around what is possible in terms of understanding patients over a long time. We've got a lot of linked data that will enable us to really do some amazing research, I think.
Yeah, Chris?
Yeah, I completely agree with that. We need it for patient management, we need it to help make the system better, and we need it for research. But we must take the public with us. And it's absolutely essential that we maintain trust, maintain openness, accept when things go wrong, all of those things. Because if we don't do that, we'll go ahead of where the public are, and then we'll end up with disasters.
So I'm going to open up to the audience in a minute to ask questions, but first I have one question I have to ask each of you, and it's called a golden thread question, because it's going to be included across all of our lectures and podcast series, which is, what do you hope our third century will bring us, the University of Manchester, in this area? Go on, who wants to start?
And I'll say, if I don't go first, they'll say the things I was
All right, go
going
on
to
then, quick, get in quick.
So, well, I think it's got to be much more about breaking down the walls of the university and being much more part of the community that surrounds us for educational purposes in a very holistic, broad sense, as well as doing research with our citizens, not on our citizens. So I think we are a fantastically civic-minded university, but I think we should make a step change in taking that further.
So, Jane, has Nikki taken your answer?
No, so I think I would value it if we had a nation where health was really valued as a primary asset for driving the economy and driving happiness, and that we had a preventative state that was foundational, so that we're really investing in communities and that the community infrastructure. I think that's been lost over time in terms of we've got very transactional public services now. I think we need a prevention-first NHS that's people-powered and knowledge-powered, and also health-promoting environments where we're using our policies to drive making the healthier choice the easier choice.
Yeah, Chris?
Well, I hope that when a CMO in 100 years gives a talk in your 300th year, they'll be able to say this was the century in which we got rid of the great majority, if not all, of the diseases of premature mortality, 75, including in the areas of deprivation, that we took away the the risks and dangers of many of the treatments for things like cancer we've got at the moment. We're beginning to see a direction of travel, but there's a long way to go. But above all, that we had shrunk the period of morbidity, not extended it by the work we've done. And if we'd achieved that, I think we could look back on what we did with some pride, although, of course, by then we'd be dead, so we wouldn't know. But, the principle is there.
Thank you. And one of the things we've touched on but not really focused on is the massive economic impact. I mean, I think it was one of your colleagues who calculated that...
Luke Mumford.
Oh, Luke, where's Luke? Who calculated, is it a third of the gap in productivity between the North and the South is poor health, which is shocking, actually. So aside from well-being and what's socially correct and all the rest of it, we could dramatically improve the economy of the weaker parts of the country. I'm going to now open up for questions. Can you wait, Matthew? And then Aravind?
Hi, I'm Matthew Moss from the University of Manchester. It was really just picking up on the conversation around digital innovation and taking people with you. But it's two aspects to it. There's been a lot of talk about the impact it might have, positive impact it might have on health system reform, but also whether you could talk a little bit more as well about that, but also on disease prevention. You mentioned it, but just that feels like a massive area of opportunity. Thank you.
Let's go first. Do you want to go first, Jane? Of the GM population with the data, how you can go in with the prevention.
You're having an internal debate here, by the way. Once we've decided, I'll go with one of them.
I've got some points to make.
Oh, it's getting past the
Okay, I'll go first, but I'll be brief. I think we saw in COVID a loosening of the rules because we had to. It allowed an acceleration of what we were able to pick up in terms of risk factors for disease, then treatments for disease, then prevention of disease with vaccines. And it also allowed us to learn a lot about the interactions with other diseases. That was extraordinary. And I don't think anybody felt that their privacy was being eroded, that they were being done down by this. We need to get that balance right, but it was a demonstration of what we can achieve, and I don't think we should go back to where we were previously, because there are so many other diseases, particularly in areas of deprivation, where getting indirect data may be the best data we'll get to allow us to focus our aims to reduce avoidable mortality and morbidity, particularly in younger age.
Yeah.
A big thing that we're focusing on in 24-25 in Greater Manchester is our approach to population health management, and particularly important that is the digital tools that we've been developing around CVD need and also around risk stratification, which Nikki was just talking about then. And they're incredibly important in terms of understanding our need, where it is, and really developing person-centred care that addresses health inequalities and targets resources and effort where it needs to be. So I think that's going to be a massive focus for us in 24-25.
And of course, one of the areas where digital is already developing some amazing tools is in predicting or diagnosing mental health issues. Just a simple video can often, and given it's prevalent in the younger people who are much more digitally literate, then that might be a very big breakthrough. It only takes one, and we know that in dementia you can track it very carefully. So, I think Aravind, you had a question.
Thanks, Professor Whitty. You mentioned this very briefly in one of your slides, but for everybody on the panel, could you say a bit more about diet and lifestyle, active versus sedentary lifestyles, and how that could correlate to health outcomes? Because naively, that may not be such a linear correlation to deprivation.
Okay, I'll go first because you're pointing at me. But I think there are two separate things. Diet and exercise are two separate things, and I think we shouldn't fall into the trap of thinking that exercise can undo the effects of an unhealthy diet. It can't. It has a huge risk reduction of multiple diseases of its own. And anybody who goes to areas which are in areas of deprivation will see that getting safe exercise for children, for elderly people and so on is harder. That's just a practical reality. It is harder. It is also often, interestingly, harder in rural areas. They look as if you should be able to get out there, but the first mile, there won't be a pavement along the road. If you're not a young person who can leap onto the bank when the car comes around the corner. You actually can have no access to this. So I think the exercise does tend to correlate with deprivation to some degree, but the dietary problems are much greater. And we have not worked out a way anywhere in the world, in my view, or certainly anywhere in the Western world, of identifying how we can have people have a diet that they are enjoying, they're satiated by the diet and they're enjoying it, and a diet that doesn't lead to obesity when they're having to do it on very, very small incomes. And this is really problematic. And I think this is really the key to those shocking data where the graph showing a gradient of obesity. We have to find a way of making it affordable and attractive if we are actually to try and reverse this trend. And I don't think we've got a good path to this at this point in time.
Jane, and you might also want to comment on government intervention, you know, taxes on sugar, taxes on fat, whatever, which
I actually think when you get into the lifestyle factors of alcohol and obesity, that actually is those population level interventions that are really, really important. And I think we need a stronger state and regulation around some of those things. And, you know, childhood obesity is a disease of deprivation. It is very much about the environment and the commercial determinants. And again, I think there's a lot more we need to do around commercial determinants at a national level, but also supported what we can do at a city regional level. And we're doing some work at the moment around restricting junk food advertising. We did some work with our UCA around the advertising that they were exposed to on their way to school. And it's absolutely kind of significant. And we can't expect young people to kind of want to eat healthier things when they're so exposed to that in their day-to-day environment. So for me, when you're looking at those lifestyle issues, we need to think a lot more about what we can do at a population level and policy and regulation.
We haven't even touched on the crisis in dental at the moment, which is multiple, but a very big one. I think I can see Ashley waving from the back. Is that you, Ashley?
Yes, it is, Nancy. Thank you.
Hello.
So I'm a respiratory physician, and I've, in my working career, seen the enormous benefits from reduction in tobacco and the related diseases. And part of that's been the prescription of nicotine replacement therapy. And so we get into a good place with that. But of course, now we see uncontrolled use of nicotine therapies, nicotine vapes, for example, which is giving us a whole new generation of addiction, I think. And I just wondered what the panel thought, especially Professor Whitty, I think, about the balance of benefits here. It's not as straightforward. It seems to me it's not straightforward.
Yeah.
Thank you.
Thank you. Well, I mean, obviously, the absolutely ideal is to get to a position where nobody's smoking. And the smoke-free generation will do that over time, we hope, but obviously it doesn't help people who are smokers now. I think my summary of it has always been, if you smoke, vape. If you don't smoke, don't vape. And if advertising to children is utterly unacceptable. That's the summary. The problem we have is that the vape industry, which was sort of allowed through the door because it is useful to help some smokers who are addicted to nicotine come off smoking, it's a very strong step in the right direction, then chanced their arm and extended it out and did exactly what the cigarette industry did, started advertising firstly covertly and then blatantly to children and to young people to try and get people who are not smokers addicted on nicotine by using colours, flavours, free samples and so on, all these marketing techniques. So I think there's a bill coming to Parliament at the moment. I consider it a very major step in the right direction. I don't think it's a panacea. I very much hope that people of all political parties will support it. The public overwhelmingly support both stopping smoking and restricting very heavily vaping. And I think we just need to take on the bogus argument that somehow being in favour of something which is highly addictive, heavily marketed at children and then kills them is somehow pro-choice. That is an unacceptable illogicality given the extraordinary damage that causes. But I do think that we need to restrict the vaping. And what's been interesting to me when I see this debate is that people who come from a child health point of view, like the Royal College of Paediatrics, would essentially like to ban everything pretty well. And those who come from a trying to help smokers to stop do want to have a range of options to help people stop something which they don't want to do. Their choice has been taken away from them. They're now nicotine addicted, and this allows them a way off. And getting the balance right between that will probably take some adjusting. And for that reason, in the bill that's going to Parliament, it's taken as powers. And what that means is we can kind of dial it up or down depending on whether we think we've overdone it or not gone far enough. That's a shortish answer to an important question. But I do think we need to avoid a situation where we go back to arguing about vaping when actually the big prize is getting rid of smoking. That is the number one priority, and we mustn't allow anything to stand in that way.
Thank you. I think we've got a question on Slido, have we? Yeah.
Thank you. Yes, we've got a few questions on Slido that have received a number of upvotes. One of the most popular has been asked by Tom Spate, who's asked the following. British Heart Foundation analysis shows that we have the highest under 75 mortality of coronary heart disease in over a decade. Have we lost progress on previous successes?
Who wants to answer that? Other than Jane or...
I think CVD has been a success story in terms of what we've achieved, but I think some of that has stalled over recent time, and we do need to, I think particularly the pandemic has maybe slowed some of our progress, and we've gone backwards in terms of our healthy life expectancy, etc. So I think we do need to regroup around how we can really get the targeted support out there to people who need it, and use some of those things we talked about before, the digital tools, etc., to really drive more person-centred care to deliver it where people need it. So I think there's a very strong evidence base around CVD, and we know what we can do in terms of if we optimise our treatment of high blood pressure and lipids, etc., we can deliver a lot, and that's the kind of thing that we are looking at in Greater Manchester in GEM for next year, is really focusing on CVD prevention and what we can do, because the evidence base is so strong, and so that's going to be a really key focus for our total system across primary and secondary care next year.
Yeah. You want to add anything, John?
I completely agree. We have gone backwards, not a huge distance, but we shouldn't be going backwards, we should be going forwards. In a sense, I think the first thing we need to do is get back to where we were just pre-pandemic. Getting the primary prevention obviously in place, but the secondary prevention, identifying people with risk factors, addressing those risk factors, and early treatment for those who need it. And both of those have been eroded during COVID for entirely predictable reasons, really. But then we should also accept that there was pre-pandemic an enormous burden of avoidable heart disease in populations we were not getting to. And I think this is where, to go back to the point that Nikki and others have made, we need to re-engage with those communities, because they weren't being engaged for secondary prevention, they weren't being engaged for, indeed, trying to reduce down the societal risks of cardiovascular disease. And I think we know where they are, we really must redouble our efforts to engage on them in the longer term, because otherwise we're going to kind of reach a plateau where we know what to do when people are wealthy and they engage in the health service, but we leave a large group of people unengaged and therefore suffering premature mortality that is entirely avoidable.
Slido question?
Thank you. And another popular question online has come from an anonymous member who's asked, how does ethnicity impact on health inequalities, and what can be done to deal with this issue, especially in multicultural Manchester?
Hugely. What's the comment on ethnicity?
Not my expertise.
Not your expertise.
I don't want to hog all the questions, but... Okay, right, yeah.
We can ask these two other times.
Okay, fine. Within ethnicity, it's important to differentiate the effects on ethnic minority groups due to deprivation, whereas simply that there's a concentration of people in certain ethnic minority groups in areas of deprivation, and the things which are biologically associated with having a particular heritage. And almost every ethnic group has certain things they're more likely to have and certain things they're less likely to have. For example, people born who are UK white heritage are more likely to have certain genetic conditions than some of the other groups, of which cystic fibrosis would be a fairly clear one. People of Asian heritage, South Asian heritage, will often have higher rates of diabetes, all other things being equal, at an earlier stage. So, but a very large amount of the ethnic differences we see in the UK are not that. They are actually a proxy for deprivation and concentration of deprivation, and we should see it as something where we've really got to tackle the deprivation, and that is the principal way in which we will address many of these problems.
Jane?
I had the privilege of leading the vaccination efforts in Greater Manchester during the COVID pandemic, and ethnicity was a key factor both in mortality around COVID, but also in terms of uptake, in terms of vaccination. And I think we learned a lot about how we need to co-produce solutions with the community. We need trusted faces, spaces and voices, and we need very different models of provision that reach out and are hyper-local for some of our groups, and we need culturally appropriate services. So I think we've learned a lot about what we need to do, and we've developed our thinking. However, I do think we need to make sure that some of our commissioning and contracting allows us to deliver these different approaches that we learned so much about during the pandemic. I feel we've gone backwards a little bit on that.
Do one more. Righto.
Thank you. Yes, another question that's just come through from an anonymous member of our online audience has asked a COVID-related question. And they've asked, did Manchester, having a devolved health care system, have an impact on the city's response to COVID-19?
That's one for you, Jane, isn't it? And maybe Nikki, yeah.
Yeah, so I think because we've got such well-established partnership arrangements, I think we were more able to kind of mobilise a whole system effort, both in terms of the governance we set up and the leadership, and also in terms of how we used our resources. So I think we were quite agile then in terms of our response and making sure we were corralling all our system resources together. So I definitely saw that difference in terms of how we responded in Greater Manchester on the issue. So I think it did make a difference.
But the deprivation meant something outcomes were worse, so probably counted.
It did make it harder, and there was a lot of challenges to face, but I think we were able to respond quite well.
I think, but also we should remember that Manchester closed down in the second wave earlier than almost anywhere else. It was from the October in the second wave, which was much longer than other parts of the country, and that had all sorts of knock-on effects for the economy and for children and all the rest of it. So, yes, I'll take one more question. Hi.
Hi, so I'm thinking about health inequalities, past, present, and future, and thinking about a future of climate change and that impact on health inequalities. Is there any comments from the panel on how we can try and address those two things together?
Interesting one. Climate change and health inequality. Gosh, well, around the world it's going to be tough.
I mean, there's a whole huge research agenda there, isn't there, that I know we're grappling with. As are hopefully lots of other people. And the funders are seeing the importance of it as well.
A lot of things that drive health inequalities also drives the climate change crisis, and a lot of the answers are the same. So again, one of the things we've done in Greater Manchester in our Fairer Health for All approach is actually combine the two ambitions, really. Sustainability and our inequalities agenda go hand in hand.
Yeah, and I think there's an international answer and a domestic answer.
Yeah.
On the international side, unfortunately, some of the countries that will be most affected by climate change early, it's going to affect all countries, are some of the ones who have the greatest levels of poverty and the least ability to respond to them. So that's at an international level, that's a fundamentally problematic and very unfair situation we're in. And then domestically, we know that for some of the effects of climate change, humans, but not all other species, can buy their way out of trouble, but only the wealthy can buy their way out of trouble. And so, unfortunately, I think this will exacerbate differences in a bad way rather than anything else. So I think we should, unfortunately, that's one of the many reasons we need to tackle climate change forcefully.
So I'm going to take the privilege of the last question, which is a cheeky question, and it's one just to Chris, but it's a question I bet loads of you want to know the answer to. How on earth did you get through that incredible time of COVID when you were on the television nearly every day, I'm sure in meetings, and by the way, we're not the inquiry, so you can give a short and a bland answer or a longer one, but for us standing back, it was pretty hard. For you, it must have been an incredibly difficult time.
Yeah, I mean, I'm not someone who particularly enjoys being on television, so I didn't enjoy it. Let's put it that way. But if you take on these kinds of jobs, you have to accept the rough with the smooth on them. My kind of view was that's the job I was given. I've got to do it to the best of my ability. I was incredibly fortunate to be supported by an incredibly good team. And I think for many people in COVID, they were on their own in their environment, working from home, often with not very good communications. It got better as the pandemic went on. So counterintuitively, I had the advantage of a team around me and physical and human contact, which helped me. At the same time, of course, I did have to have exposure, which I wasn't ready for, and I was on a very steep learning curve, to be honest, but there you go. But teams make an enormous difference.
Yeah.
And I think that's true across all of healthcare, whether it's nursing, medicine, science. You really rely on your teams. Building a good team around you makes absolutely terrific difference when the chips are down.
I should add something that Chris said in another venue. It was good working in teams, but not going to any parties, I recall.
No parties.
But can I say a huge thank you to Nikki, Jane, and to Chris. Thank you.
If you enjoyed listening to Professor Chris Whitty's lecture on health inequalities, be sure to stay tuned for the rest of our Talk 200 series. We'll be speaking to a diverse lineup of guests, including staff, students, academics, and other notable figures who will provide insight on a range of issues spanning cutting-edge developments in digital and AI through to inequalities in accessing justice in legal systems with the university's Chancellor, International Advisor on Rule of Law and former Chief Prosecutor Nazir Afzal, delivering a talk on the latter as part of University Manchester Festival on 7th of June. To stay up to date with everything Talk 200 and join us as we look to what our third century could bring, exploring topics such as health through to climate change, be sure to follow and subscribe to the series on the podcasting platform of your choice. Head to manchester.ac.uk/200 to find out more about this series and all the activity taking place across our bicentenary year, including our free festival, University Manchester, from the 6th to the 9th of June. Use the hashtag UOM200 to engage with Talk 200 and our wider bicentenary celebrations on social media. Thank you for joining us for this episode of Talk 200, a University of Manchester series. Until next time.